get started with Dr. Baker talking about polypharmacy.
All right, welcome everybody. So today we'd like to hopefully accomplish at the end for you all to be able to identify what polypharmacy is, identify factors that lead to polypharmacy and the consequences from polypharmacy. Also identify some common medications which are potentially inappropriate for the use in older adults and those with dementia, and also discuss why it's important to consider simplifying a medication regimen as dementia progresses in someone. So does anybody out there have an idea of what polypharmacy is?
Way too many medications.
Okay. Anyone else? Okay, so polypharmacy, there's not really a true definition. I like your statement of way too many medications. There's no consensus on really a true definition. Typically, we say it's 5 or more medications. Some of those medications may not be clinically indicated, or they may just be medications that are inappropriate, potentially for an older adult. In addition to prescription medications, you really have to look at OTC products, herbal supplements, and vitamins. There are a tremendous number of folks that are on those medications. We'll talk about that in just a second. So how do we get to this? This, if you can see that tackle box kind of in the front of that big box, was 1 week's worth of medications brought in by a client at our geriatric clinic. She had 10 prescription medications and 19 supplements that she took every day. So that is 1 week's worth of pills there. It's hard to imagine how she managed to do this and still was able to eat anything at the end of the day because her stomach was full of all this stuff, but she did. So despite our best efforts to try and dissuade her otherwise. So just talking for a minute about medication use in adults 65 and older. The CDC did a study from 2011 to 2014, and they just asked people 65 and older, what percentage of them were taking 5 or more prescription medications in the last 30 days? And it was about 41% of those folks were taking at least 5 or more medications. And you'll see in a minute why it's really easy to get to that. Looking at the most common classes were medications to lower cholesterol, lower blood pressure, lower blood sugar, and also to treat heartburn or reflux disease. So you've got 4 really common classes there, and some of those are going to require more than 1 medication to treat. So it's really easy to see how you can get to 5 medications. I didn't include on the slide, but data from back in 2012 said that about 35% of folks 65 and older were taking supplements. I would venture to say it's probably significantly higher than that. We rarely see anybody that isn't taking at least 1 over-the-counter supplement that is not prescribed by their physicians. So what leads to polypharmacy? And this is just kind of a list of some of the common things. There's definitely lots of factors that go into that. Multiple chronic illnesses, as we just talked about in the previous slide. You look at older adults that have high blood pressure, high cholesterol, diabetes. It's really easy to get to 5 or more medications there. Lack of an indication. Somebody gets started on a medication at some point, and then they just continue on that medication. And that kind of also coincides with the treatment duration of medication. They just get started and then they switch physicians, or they go into a hospital and come out, and some of those medications that get started never get stopped. So that's a fairly common reason of why we end up with so many medications. Multiple providers and multiple pharmacies is another reason. We have our great systems of electronic medical records now. Unfortunately, it is not a universal system, so if you are seeing a physician that's in one system and then you go see another physician that's in another system, they can't see the lists of what each other is prescribing. So that, although it is helpful, that we really end up with still inaccurate reporting of medications. There's the expectation to receive medications. Our society believes that when you go to the doctor, the expectation is you're going to come out with a prescription for something, and that's very common, and that unfortunately helps lead to polypharmacy. And then self-treatment. From the OTC perspective of medications, you've got treatment of heartburn. There's several of those medications are now over the counter. I just read something this morning that there's going to be a push to make more medications over the counter. And so people are able to do self-treatment, and all of the herbal supplements and vitamins and all of those things all lead up to polypharmacy. And if anybody has any questions, please feel free to jump in and ask.
One thing, Dr. Baker, as I was going to go through this, one thing I realized, sometimes physicians actually do inappropriate prescribing, which can also lead to polypharmacy. They diagnose you with something that, you know, sometimes we're not perfect, and so sometimes we make the wrong diagnosis and we give you a medicine for it. And if you didn't have that diagnosis, you don't really need that medicine, so that can lead to polypharmacy. And sometimes we just start way too high on doses of medications, and polypharmacy, not only number of pills sometimes, but just the amount of the milligrams or the micrograms that you're taking too can kind of be considered in the polypharmacy spectrum.
And when you start a new medication, sometimes they start having adverse effects, which is counted as a new illness again. So a pill for every year, there was a pill again. So that could be one of the important factors too.
Okay. So what does polypharmacy lead to? There's all kinds of things that this leads to. There's an increased risk of adverse drug reactions, which we're going to talk about in a minute. Increased risk of drug-drug interactions or drug-disease interactions. So you're taking something that's either interacting with another drug that you're taking, or you're taking a medication that may not be the best choice for another disease state that you have. We see that fairly frequently, especially with the older adult population. Many studies have shown that polypharmacy leads to an increased risk for depression, sedation, delirium, falls, functional decline, so decrease in ability to do ADLs and IADLs, increased healthcare dollars, definitely. And the potential for undertreatment. If you're a prescriber and you see somebody's list already has 10 or 15 medications on it, there's that hesitation there to think, oh, do we really want to add just one more onto that list? So it's kind of, you're contributing to the polypharmacy, and so there's just that struggle there, I think, that goes on sometimes. Have anything you want to add?
Yeah, I echo all of that.
2 more times.
All right. So what is an adverse drug reaction? And this kind of goes back to what Dr. Sharma was just saying, that something happens, so we give you another medication to treat something that may not really be a disease state. So an adverse drug reaction is an event that's harmful that happens because of a drug that's given at a normal, appropriate dose for somebody. Some common symptoms that we see from the adverse drug reactions are confusion, nausea, falls and balance problems, sedation, change in bowel habits. And these are all things that we commonly see in older adults anyway, so it becomes very difficult to figure out what is due to a drug as a side effect or an adverse reaction and what is actually a new disease state happening. This leads to what we call the prescribing cascade, where somebody goes into the doctor. A good example is a medication used for restless leg syndrome. and they start taking this, and then they go to the doctor with their family member because they've been having hallucinations. So then we think, oh, there's, something is happening there, and we prescribe an antipsychotic to treat those hallucinations, when in reality, it may very well be a side effect from that medication that we're giving them. So that creates what we call the prescribing cascade. Just meaning that one medication is given to treat a side effect of another medication.
Okay, now that Dr. Baker did talk a little bit about polypharmacy, I'd like to open discussions for any of you might have any more questions on what we just discussed, or any other cases you want to review with us.
If you have any questions or cases or anything, please feel free to take yourself off mute with the microphone icon on the Zoom screen. Raise your hand if you're on video and I can take you off mute. Or there's also the chat box that you can write things into. So please feel free to, we'll open up for questions or comments or anything at this time, please.
Okay. So any of you in the audience are prescribing any medications? No, okay. How about, how many of you are in charge of administering medications? No? Okay. Okay.
Just have some nods.
There's some nods, okay.
Yeah.
Can we unmute?
This is Arlene from Boulder City Hospital. I am an RN. I am the risk manager, so I help the departments. My director of nurses is also in her office. I don't know if she has ability to speak, but this is something that we see in our long-term care and our geri-psych department. This is a big deal, and that's why we're both here. So we are in charge of the nurses that do give meds, to answer that question.
And I know we just won't go on the number, but how many on average have you seen your patients being on? How many medications would you say?
I don't know if Lee's able to.
I am. Can you hear me?
Oh, there she is.
Yes.
Yeah.
I'm Lee.
Hello.
Thank goodness. Anyway, yeah, the majority of our patients, I have 39 patients right now, and probably 37 of them have more than 5.
Yeah.
And yeah. And how many times do we see that they don't want to take their medications, dealing with refusal?
Yes, I would say about 10% of my patients, and that's usually related to dementia or something like that. Not always, but usually.
Yeah. Okay. Okay. Thank you for that information.
You're welcome.
So let's move on. So here's a case about Mrs. J, a mutual patient of Dr. Baker and me that we saw in our geriatric clinic. Mrs. J is a 75-year-old female who came to our clinic with her husband and a daughter, and the chief complaint was memory loss. At the time, she was living in a single-family home with her husband. Memory loss typically was slow and progressive over the last 3 to 4 years. Her daughter, who she had seen maybe 4 years prior, noted a significant decline. Mrs. A did not have a stroke, but had very limited physical activity. She did have a lot of significant comorbidities, and to mention a few, she did have diabetes, high blood pressure, hyperlipidemia, low thyroid, macular degeneration, COPD, depression, urinary incontinence. She did not have any falls in the last 3 months, did not recall in the last year though, and had not lost a significant weight. On exam, she looked a frail, elderly female, was in wheelchair. We did a brief memory screen, mini-cog, that's what we usually do in office practices, which has 3-word recall and a clock draw task. She was not able to remember any of the words and was not able to draw a clock. So she screened positive for dementia. We scored her depression as per the standardized scale that we call PHQ-9, and she scored highly at 18. She was fatigued most of the times, had more than 5 illness, was not able to climb a flight of stairs nor walk a block, So this categorized her as being frail. She was dependent in most of her activities of daily living and all of the instrumental activities of daily living. Now let's look at Mrs. J's medications. In this slide, I know it's crowded because she's on a lot of medications that we can see. There are 11 different medications. For blood pressure, she's on metoprolol once a day and clonidine 4 times a day. For diabetes, she's on metformin and glyphosate. We'll get in details how she's getting that later. She's also on antidepressant fluoxetine, allopurinol, levothyroxine, Advair that she was only doing once a day for her COPD. Besides that, she was on aspirin and oxybutynin for urinary incontinence. Good thing was she was not taking any over-the-counter medications, and she was not on any pain medications. Remind you, she did have a script for pain medication, which was an opiate. She was not taking it, and she was not taking Lyrica anymore. At the time of exam, she was not on a lot of pain. We didn't have any labs that day for review. The medications that our pharmacist, Dr. Baker, identified as being inappropriate for her definitely was oxybutynin and clonidine. For diabetes, her blood sugar was being checked every morning, and medications were given if the blood sugar was more than 90 or 91. Glyphosate, which is extended release, was being cut in half, which should not have happened. And for COPD, as I mentioned earlier, she did not appear to be in any distress, did not have any wheezing. She was on the inhaler Advair only once a day. So when after we heard the history, did the exam, definitely she had dementia. And as she was dependent in most of her activities of daily living, I would say at least moderate or severe dementia at that point, and she was not able to organize her or administer her medications on her own. So the caregiver stress was speaking out loud. Her husband besides giving the medications, was checking blood pressure every day, blood sugar every day, was dealing with the complicated patient instructions like give the blood sugar medicine if the blood sugar is more than 90 or 91. A lot of pills. She was taking at least 5 times a day of pills. That spoke of frequency and definitely pill burden. And besides that, she was also being given the medications, as we discussed before, which were potentially inappropriate and had more side effects. She had started refusing to take medications, which was being going on for the last 6 months or more, and that created marital discord. So caregiver stress was a big issue that we saw in that particular encounter. So as a result, medications were not being given as prescribed, and we are not even surprised why. So after seeing her, there were a couple of things that came to our mind. First of all, she's on a lot of medications. Does she need to be on all this? And how are the medications helping, or if not helping? And what is her life expectancy? At this point, I would like any of you in the audience to maybe make a guess on what is her life expectancy, how long you think Mrs. J is gonna live. Any of you want to take the chance?
There's no wrong answers.
Yes, and she is 75, has pretty severe dementia. She's dependent on her activities of daily living, and to say her health is fair to poor.
And then if it makes you feel better, physicians get this wrong half of the time.
Yes.
So,
any guesses?
Low bar.
This is Lee. I'm going to guess less than 2 years.
Okay.
Okay, thank you.
Anybody else?
I'll concur.
Okay. And I mean, when I did put her data on the calculator that we commonly use, that's called e-prognosis. I know in previous ECHO we have had discussion about that. So I calculated 2.9 years. So you're pretty close. Thank you for that. Yes. The next thing we did have to address as geriatrician was what are her goals? 75, has dementia and stressed from her family. So her goals at that time was to be able to spend more time with her family and kids, and try to see if she can take less pills. The other thing that we deal every day in our everyday practice in the patient and the family who have dementia is caregiver stress. We see that and try to address that as we go on. And thank God in our clinic we had a social worker who helped us deal addressing caregiver stress. But me and Dr. Baker, we could do something to help the patient and the family. That's to look at the medications again and see if we can simplify the regimen. And I'm gonna try to do by all the chronic medical illness that she had. First of all, let's start with high blood pressure or hypertension, because we thought that was one of the problems, because she was being given 5 medications, and especially clonidine, which was 4 times a day. So did she need to be on all that 5 medications? We thought no. She, at least for clonidine, it does carry the geriatric warning that it's not appropriate for geriatric patients, and 4 times a day was just not appropriate. So the suggestion that went to the family and obviously to the primary care provider was to try to simplify the regimen. Maybe try to pick a medicine that she can take just once a day. And as target for the goal blood pressure, she's pretty she's not very functional at this point. So her blood pressure does not need to be around 120/80. We can have a lenient target, and then if her blood pressure is controlled at a good number without having to take pills 5 times a day, that should be our goal. So that was the suggestion we made for high blood pressure. For diabetes, the history was a little bit complicated. If she was on 2 medications, metformin and glipizide, and the blood sugar was really more than 90 or 91, and she was taking medication 2 or 3 times a week. So the way I said for high blood pressure, even for diabetes, we do not treat a 75-year-old with dementia the same way we would treat 30 or 40-year-old with diabetes who was pretty functional. Or even to that matter, 75-year-old who was pretty functional can take care of his own medicine. We would treat diabetes differently. So for her, we definitely needed to have a lenient target of the number that we call A1C. That's the measure of blood sugar in the last 3 months, around 7.5 to 8%. That was fair as per our discussion in that day. So what we advised was definitely not to cut the glipizide into half, because we don't know.
When you cut an extended release product in half, you've just destroyed the extended release mechanism. So she was getting a huge dose of the drug, which was probably dropping her blood sugar really low, and she could have symptoms of low blood sugar then. And then it's going to spike back up. So, cutting an extended release medication, there's just very few that are designed to actually be cut in half, is just not good practice.
Question here, should retail costs be considered for any prescriptions that are offered, since elderly patients are frequently low income?
Absolutely. Absolutely. I mean, especially when treating diabetes now, there's so many of these new brand name medications that are very, very, very expensive. And I think one of the things that you really need to look at before you start adding on these new expensive ones is you may have been prescribing those less expensive meds, but were they really treating them or taking them, excuse me. I see that fairly frequently, that they aren't taking them, and then the prescriber feels that, their blood sugar isn't in control, so we need to add another one. But they really weren't taking the first one in the first place. So absolutely.
So for high blood pressure on this particular lady, we have cut down to 1 pill. The same goes for diabetes too. If she could tolerate the metformin, that would be the thing to go on, rather and people who are only using metformin do not typically have to check blood sugar at home. I mean, if it's cutting down the caregiver stress, if only on metformin, we ideally don't have to check blood sugar rate, at least not once a day. So that's thing to consider. Any other concerns you might have for diabetes or high blood pressure in your patients?
The one thing I would add is whenever you're treating kind of these big disease processes, you have, and kind of Dr. Sharma mentioned this earlier, you have to really think about their life expectancy. Lots of times we treat diabetes because we're hoping to see improvements 5-10 years down the road to avoid those microvascular complications like retinopathy, neuropathy, and nephropathy, essentially issues with your eyes, kidneys, and nerves. And then also you always worry about those big heart attacks and strokes. So that's a big history point that we like to take. But if you don't have the history of heart attack or stroke, you know, we're not 100% positive you're going to be living longer than 5 years. A lot of these more aggressive interventions aren't necessarily in the patient's best interest because they won't necessarily be around to reap those benefits.
Thank you. Okay, the third one, the big diagnosis was definitely depression. She did score highly on her PHQ-9. So, and again, she was on an antidepressant that was Prozac. And Dr. Baker can tell us why it's not so appropriate for her for the use.
So there are many people that take Prozac every day, but you can actually dose Prozac just once a week because it lasts so long in the body. It takes a long time to clear that drug out of your body, which is definitely not good for an older adult. If something is going on, there's the question, is it due to the medication? Is it another disease? And it takes so long to actually clear the entire drug from your system. So we really try and avoid that. And then also there's several drug interactions with Prozac. So it's another reason why we really try and avoid that in older adults.
So typically the safer SSRIs would be?
So Zoloft or Lexapro,
Generic.
yeah, sertraline, escitalopram are two of the ones we prefer to use frequently.
And for her depression, definitely other strategies like she wanted to be around the family, maybe increasing physical activity. Those are the other things that we stressed up on besides just the medication. But they're definitely after trying a different SSRIs, PHQ-9, that's a good tool to see if anyone would benefit or not. Typically, we start out with starting the medication, and in around 2 months, you can have the patient again, or even in the phone interview, you can do the PHQ-9 and see if their depression is getting better or not. The scores around improvement of around 4 or 5 is clinically significant. The other issue that she had was COPD, and what happens with advancing dementia is you lose so many different learning, especially learning new things. On her, she was having to use inhaler, and we had we just wanted to see how she was doing. So we had her do it at least 4 or 5 different times.
And even with instructions, she could not use the inhaler. I mean, I sat with her and demonstrated and really tried to have her repeat back to me what I was showing her, and she could not do it. So really, she's on a very expensive inhaler, which was probably, the costing her $100 a month. And then on top of that, she was really not getting any benefit from it because she was not using it correctly.
How long did it take you guys to like, as you guys gave her the inhaler and tried to have her use it, how much time did you spend like watching her and navigating that?
I spent about 10 minutes with her.
So not a little bit of time. It was
Yes.
took some time to figure that out.
Mm-hmm.
Exactly.
And even though we gave the instructions, she was just not able to follow the directions. So either to discontinue the medication or try something else if we really need to treat the COPD. And again, like I said, she was not in distress. She was very limited in her physical activity. So, I mean, if it was against the goals of care or if it was too much burden at that time, discontinuing the medications would be appropriate. The other thing we were concerned about was her urinary incontinence. She was on oxybutynin. I don't think we knew for how long, for about 2 years or more, I guess.
Yes. It's a while.
Yes. And with her dementia, she should not be on oxybutynin.
And so oxybutynin is to help increase urinary continence, and she was wearing diapers. So why we're giving her a medication to help, with urinary incontinence when she's using diapers anyway, just doesn't make a lot of sense. Oxybutynin, some of the common side effects that we see from that, obviously urinary retention, that's why they're using it. It can cause vision problems, confusion, increasing falls, constipation. Not a good medication to use in any older adult, but also it, with the dementia is a significant concern.
Yeah, and to tie back into what Dr. Baker said earlier about what causes polypharmacy, anytime we prescribe a medication, we have to come back, make sure there's good follow-up, make sure that it's working for the indication we prescribed it for. And that will kind of avoid a lot of these issues 2 years down the road. You could have figured this out maybe 3 weeks after starting the medication, and then it wouldn't have been an issue.
Yeah, and to add on that, more than 3 or 4 times what we've seen is like for people who have dementia, you sometimes start on medications like Aricept or donepezil, which is cholinesterase inhibitors, and the most common side effect is for that you use oxybutynin. So you get started on Aricept, and then you put them back on oxybutynin, which works in contraindication to each other. So that's what we see all the time. And even for urinary incontinence, the simpler advices for her was to increase physical activity. There was functional urinary incontinence as well. So if she was being more active, going to the bathroom on time, that would help her and be away from the pill too. So this brings us to, so far we discussed about the medications that she was on for the medical conditions that she had. But now, like Dr. Lavi said, there are some medications that we commonly use for primary prevention, and for that, definitely we need to look at life expectancy, like we just discussed. If we are aiming to treat for a condition that could happen in 5 years, and the life expectancy is 3 years, you shouldn't ideally be using that medication, especially with advanced dementia. If you diagnose early, in the case of dementia, the life expectancy could be around 8 years, but with progressing dementia, it usually shortens that. And according to a new data recently published in AGS, around 2/3 of the people with advanced dementia who get admitted in the nursing home, their life expectancy is around, they are supposed to die within 6 months, around 77%. So that's pretty significant. So you need, at that time, if the dementia progresses, especially to the fast 7, that means they are at the nursing home. All the medications that we use for dementia, there are a couple of medications that we use, should be discontinued. The other good thing about Mrs. J, like we said, she was not on any pain medications, but she did have a script for opiates. Any of you want to elaborate more on opiates and dementia?
Again, you want to, treating pain is to maximize functionality, in my opinion. And so because somebody has a prescription and not using it, it's showing that they're not really needing it to maintain the function that they're looking for. And you definitely don't want to be prescribing things that people aren't taking. And this was something I wanted to kind of share, so this might be a good segue. For those of you that work in nursing homes or take care of patients in the outpatient setting or even inpatient setting, one of my triggers for kind of talking to nurses and talking to providers about appropriate medications is if you see more than one or two refusals in a row, something's going on. It needs to be addressed. Polypharmacy is probably happening, maybe some other things too. And so that could be kind of a quick trigger, being like, okay, what's going on here? We have this medication on board. The nurse, the medical assistant is putting in a lot of work to try and get our caregivers trying to get this medication in. How come it's not working? Do I really think they need this medication? Is there some other better option? And that was my kind of short on kind of segue from chronic pain. Yeah, most things are supposed to have a purpose, and you definitely don't want to be prescribing things that don't have a purpose.
And a lot of time we do see people with advanced dementia and opiates.
Yeah.
So say more about opiates.
Yeah, I mean, obviously everybody is pretty aware of the media coverage that it's getting. And it really is true. I mean, and you will see this, that, you know, the people have been on this for years and years, and it is a tough challenge to get them to even think about looking at to stop taking them. It's especially with the older adults that are experiencing constipation all the time anyway, and maybe taking other medications that are contributing to that. The opioids certainly are. The risk of falls and breaking a hip is significant. The opioids are going to increase that risk of falls, the confusion that may be going on. And I think a lot of them, you know, back if they started this 5 or 10 years ago, the thought was we're just going to give them an opioid and we're not even really going to look at doing a topical agent or physical therapy or a OTC product or something like that. And then it just kind of snowballs into continuing these when they really haven't even tried anything else. So it's always best to try and at least get them to start thinking about it and why the opioids are not good for them, and especially if they're independent living and, you know, and cognitive function is a concern, and falls certainly. You know, that's a great place to start with, you know, keep wanting to keep them independent and living on their own. That's a, you know, great place to start talking to them about getting off of the opioids or look at alternative measures to treat the pain.
Exactly, and I know we cannot emphasize enough, but these days we are doing a lot of scheduled acetaminophen or Tylenol. Up to 2 to 3 grams a day should be safe, and, you know, instead of trying stronger medications like NSAIDs, which we know, I'm sorry for using the abbreviation, non-steroidal anti-inflammatory drugs like ibuprofen or other, which do have more side effects in our older adults. Tylenol is a little safer, I would say, along with local treatment, that the more you can do is better. We know Mrs. J is definitely frail, right? So we talked about how we can reduce medications. Polypharmacy does have impact on frailty. The higher number of medications, usually they are more frail. More than 6 or 7 medications, we are definitely looking at somebody who's pretty frail, even though you adjust for the disease burden. So besides simplifying the regimen, maybe optimizing nutrition, increasing physical activities would be other recommendations for our frail older adults. This brings us to the other medications that we know and we've heard about for dementia. Any of you in the audience would want to share the medications you might know that we use to treat dementia?
Well, Namendo is one of them.
Okay, that's a good one.
Aricept?
Yeah, Aricept, yes.
Yep, donepezil. Yep.
Yes. And thank you. Those are the most commonly used medications that we see being used in dementia. And I wish it was otherwise, but the effects has not been so promising. The thing that we know definitely works more is physical activity rather than taking the medication. It's not to say that it cannot be tried in people who has, you know, mild to early dementia. It's pretty functional and they don't have a lot of side effects. But the person whose dementia is progressed to this stage, we don't have a lot of benefit that the medications is beneficial compared to the side effects it might have.
Yeah, the main role kind of in my practice for the anti-dementia meds are for patients that are still at home, maybe having a little struggling. These medications might give them a couple more months at home before they need to either hire more care or move to a higher level of care. The main evidence suggests that there may be some slowing in the progression of your decline of your activities of daily living, which are cooking, cleaning, grooming, eating, transferring, and toileting. So those are the types of things that if you're noticing people having a little bit of trouble with it, might be limiting their ability to stay at home safely, that might be a person to consider trying the medication on. And then again, to avoid polypharmacy, you need to follow up make sure it's doing the thing you thought was hoping it would do, and if it's not, stop it. Lots of side effects with these medications.
Especially with, in that population, falls, they can definitely increase that risk for falls. So if you have diarrhea, if you have somebody that has toileting problems anyway, and now you're giving them a medication that's giving them diarrhea, you can imagine the caregiver stress and that it's distressing to that person having that issue. So we, really, as he said, to reevaluate, is it doing any beneficial or is it just better to stop them?
Yeah.
And we also see a lot of loss of appetite, weight loss in this age group, especially when the dementia is advancing. So, and those medications do have those side effects.
Yeah. Going back to the falls thing, the donepezil, the Aricept, the Galanti, I guess we don't have that one in the US, but and the Exelon patch, the rivastigmine, can all cause bradycardia or slow heart rate. And so I don't think enough providers in this area know about that. So I just kind of share that every time. Is that if you prescribe those medications, their heart rate will slow. Lots of these patients already have a history of heart attack, heart failure, and so might already be on another medication that slows their heart. And if your heart's only beating 40 times a minute, you try and stay conscious. So I've seen that a lot. People get pacemakers without getting stopped, without this medication getting stopped, and so it's unfortunate.
Yes.
So since we're talking about it, I wanted to share it.
And I think in the last 6 months, we might have seen 2 unexplained falls and syncopal episodes, and the patient was on an Aricept. So it's a big point that I hope that gets across.
Yeah.
Okay. Do you have any other concerns, any other medications that you want to discuss at this point? So there are a few take-home points that we would like to emphasize on. First of all, know all the medications, be it over-the-counter, those prescribed by different providers. And a lot of times, the medications that are not self-disclosed by the patients are over-the-counter medications, and a lot of benzodiazepines. Those are the 2 classes of medications that patients usually don't self-disclose. So ask about those medications, and like Dr. Baker said, even over-the-counter herbal supplements, sometimes they could be taking other medications which could be interacting, and we don't know how much the medication is helping you or not. So making a up-to-date list of all the medications is really important. It's important as prescriber, as a patient, and even as a patient's family, to make sure the doctor has up-to-date list of all the medications. The next important thing that we cannot emphasize enough is non-pharmacological strategies. As we get into more dementia, I know we'll be talking about in each separate discussions, but try to do non-pharmacological strategies as much as possible, and try to cut down the medication. Not every ill has to have a pill. So that's important to get across. The other most important thing is, every time you think there's no pharmacological strategies that you could use and you have to use the medications, we need to know why we are using the medications. What's the desired outcome? How long the person is going to be on that medication? When is the stop date? What are the side effects? And how to minimize the side effects? So that's really important. Besides that, there is for patients, for prescriber, there's a good website that's called prescribing.org, which is one of the important community tools that you can look up. The other thing I know we should have included and did not include was maybe a Beers list.
What's the Beers list?
So the Beers list is created a list of medications that are potentially inappropriate in older adults. It doesn't mean by any stretch of the imagination that you should never use any of these medications in an older adult. It just means that there's kind of a yellow sign there that we need to stop and take extra care and caution to look at that medication, and they list the whole, arrange the gamut of different kinds of medications. There's lots of them, but they all have specific reasoning as to why they may be inappropriate for older adults. You can Google Beers criteria or Beers list, and it's really just something to send up a flag to say, hey, maybe we need to take a look at this medication because it falls on this list. And I think I can't stress enough to what Dr. Sharma was saying is every time you start a new medication, reevaluate it again. And I think as family members and caregivers, feeling comfortable and confident to go back to your provider and say, can we just look at this? Do I still need this? Or for your family members to say, we want to just reevaluate all of these again. And that's really important for everybody, I think, to feel comfortable with doing that with their provider.
Cool. So you guys have any questions? I think that's what y'all have. We have today.
Thank you.
You're welcome.
You're welcome.
So this is gonna type in. So just feel free to interrupt or type in a chat box. So I think this is our first of 4 lectures. The next one will be on delirium. Dr. McCaleb is going to give that. He's one of our community faculty working at the Veterans Association. Very charismatic guy. Enjoys conversations and talking about things. So that'll be a great one to log into. I'll be doing the one on dementia afterwards, talking about the different types and then talking about how to deal a little bit with dementia with behavior disturbances. And then our last one will be given by our PhD social worker at the Sanford Center. He'll be talking about capacity in the geriatric patient. And so those are the topics coming up. We would love to hear what you guys liked from this echo, what you guys want to hear more from our geriatric echoes, what works well, what you never want to hear again. We're open. We're here for you guys. So we want to know what you need so we can serve your needs.
And please, if you have any cases for review, please submit the cases so that we can provide our expert consultation. I think that's the time.
Yeah, we know it's tough to get a hold of us and get people to see a geriatrician, so we want to share our knowledge with you and empower you guys to take care of these older adults, because that would make us the happiest, I guess would be the way to say that.
Okay.
Thanks again, guys.
Thank you all.
Thank you.